Getting better at this. Okay, we're getting started. Thanks for coming to Medical Grand Rounds today, the hopefully last day of winter. We're really excited to have Dr. Fortinsky here with us. For those of you who don't know, Kyle is one of our gastroenterologists. He's a hepatologist, therapeutic endoscopist who's been practicing here since 2019. He's also does scopes and works at RVH General. His background is he did the MD at University of Ottawa, followed by internal medicine, GI, and histology fellowship at Toronto. He completed fellowships in GI malignancies, pancreatic biliary disease, and therapeutic endoscopy at the University of California, Irvine. He's the regional colorectal screening GI endoscopy lead for the colorectal cancer program. And he performs advanced endoscopic procedures, including diagnostic and therapeutic endoscopic ultrasound, endoscopic retrograde cholangiopancreatic those ERCP. Just probably know that. And advanced polypectomy for large gastric, duodenal, and colon columns. So we've got interest in blind and pancreatic biliary disease. And for those of you who work with Kyle, he's in addition to just being a great guy, he's a great colleague. He's kind to his patients and always there to answer questions and provide expert advice. So we're pleased to have him and pleased to have him here today. So round of applause for Kyle.
Thanks so much, Chris, for basically volunteering me for this talk. So we're going to be talking about acute pancreatitis, really focusing everything from diagnosis to discharge. A couple disclosures, a couple speakers. Evidence is evolving, so some of the things you may have learned 10 years ago, even when I was in medical school, is changing. So things I'm going to say are subject to change. And also my life's much less interesting than Dr. Anna Ingrid. And I actually would like it to be on the record, and I know this is being recorded, that I never ever want to speak a week after Anna Ingrid. I think like literally the superstar of the hospital, and like, oh yeah, next week it's Kyle. Thanks for that, Chris. So I haven't gone all over the world or done anything interesting, but just a little bit about me. For those of you that don't know, I grew up in Thornhill, not that far away. Went to Western for undergrad, over to Ottawa for med school, where I met my future wife, back to Toronto, to California for a couple of years, and days like this, I don't know why I came back. And then Barry, and those are my two little girls in the heart. That was last summer. So sort of full circle, but again, these pictures compared to Anna's pictures last week are kind of like whatever. So there's been a really nice guideline that's come out in the last couple of months that I really urge everyone to look at if you're at all interested. It gave a really good approach and clinical evidence, which form the basis for a lot of the things I'm talking about. It's very practical and evidence-based. So what are we going to talk about? So approach to initial management. Identifying the cause and managing complications. So here's a theoretical case, but we've had lots of cases like this guy to illustrate some of the key points. So this is a young, healthy guy who has no medications, doesn't drink alcohol, one-day history of severe pain, nausea, vomiting. Obviously, this is a talk about pancreatitis, so it's not a huge surprise. His vitals in the ER is a little bit hypotensive, with blood pressure of 160. He's a bit tachycardic. He's sounding well on the air, etc. White blood cell counts elevated, BUN, creatinine are both elevated, liver enzymes, bilirubin are normal, and lipase is elevated. So initially, emerged doctor orders an ultrasound, gallbladder looks normal, no bile dilation, pancreas is edematous, and so this patient's being admitted for presumed acute pancreatitis. So obviously that one's fairly obvious, but what actually classifies diagnosis really relies on two of three things. So one is the type of pain. So it's usually acute onset, severe, tenderness on palpation. You need to see a form of enzymatic elevation, so either lipase or amylase. Lipase in general is more sensitive and specific, so we prefer that. And then the third thing is evidence of acute pancreatitis seen on some form of cross-sectional imaging. So you only need two of the three. So this will come up later, but if you have pain and elevated lipase, you don't need the imaging to confirm that. If you have pain, normal lipase, sometimes the imaging will suggest So it's important to understand that you don't necessarily need anything for each patient. So there is a differential diagnosis, and we see this fairly often, and I'm sure as primary care providers and nerve doctors can see very mild elevations in lipase, and often patients might have mild discomfort, and there's always a question of, is this pancreatitis? Typically in pancreatitis, it's quite high. So depending on the lab, the assay will give you the upper limit of normal, and typically if it's not more than 3 times the upper limit of normal, if you're not usually dealing with acute pancreatitis. Minor elevation, very commonly, we see in patients with duodenitis, peptic ulcer disease, and often there's a slew of things, but these patients are typically very sick, either with acute cholecystitis, with bowel infarction or perforation. Patients with chronic kidney disease will have mild elevations in lipase, and often some of our patients on various antibiotic medications will also be. So very low grade elevations in lipase can be seen in a variety of things. And when people have very mild chronic pain with a mildly elevated lipase, I would think about other causes. Just to throw that out there. A key point to remember is once the diagnosis is made, especially when we're dealing with acute pancreatitis, there's absolutely no reason to ever repeat a lipase again throughout their admission in the hospital. So I've seen, people, repeating lipase over and over and commenting about, oh, the lipase is trending down, or oh, the lipase is normalized, or the lipase is going up. The absolute value of the lipase has absolutely no correlation with the severity of pancreatitis. So seeing a level that's 20,000 or 300, it doesn't change how you manage the patient. It's all based on a clinical presentation. And similarly, once you've made the diagnosis, the trend of lipase afterwards is completely irrelevant. So that might be one thing to take away, because I see that being often done, and you're not harming the patient, but it's just you're not adding anything either. So initially, an ultrasound is typically the best first test. It's easy to get. You might see signs of pancreatitis, and you can also look at the gallbladder and bile duct to get some information that might help with management. A CT with contrast is very helpful, but it's typically best done a few days after the initial presentation, because we can start to distinguish if it's either inflammatory predominantly or necrosis, and necrosis tends to come with worse outcomes, and I'll discuss that in a bit. But the initial CT that's done sort of in emerge isn't typically very helpful, does not change management, and it really should be used to rule out other potential causes, if that's what you're worried about. And typically during the admission, if we're looking for more specific things like small stones or microphysis, so sometimes evidence of sludge and things that we can only see on EUS, or if we're worried about a cancer or something like that, we can get an MRI or EUS, but it's not typically like one of the first tests. So when we're looking at severity, we classify sort of into mild, and then there's, I don't really like that much, the term is moderately severe and then severe. So mild is patients coming in with no end organ dysfunction, no systemic complications, they're clinically well. It's almost tempting probably in emerge to maybe discharge these patients, but they would still need to be admitted to hospital for fluids. Moderately severe, typically these patients come in sick, but they resolve after about 48 hours in terms of signs of shock or renal dysfunction. And then severe, which is really what we're most worried about, are patients that have persistent organ dysfunction after the first 48 hours. So why do we care so much about acute pancreatitis? So the mortality is very high, but it really depends whether you're dealing with acute interstitial edematous pancreatitis or necrotizing pancreatitis. And you can only determine the difference about 3 days or so after their initial presentation with a CT with contrast. So 80% fortunately are interstitial edematous, and this is the milder course that tend to have mortality of only 1 or 2%. Necrotizing pancreatitis mortality can be as high anywhere from 14, 16, sometimes even higher. And really, there's 2 flavors to the mortality in acute pancreatitis. So there's early, which is in the first 2 weeks, which tends to be multi-organ failure, and late, which tends to be complications of necrosis, which we'll talk about a little bit later in the talk. So the big takeaway, number one, and we'll have a few of these, is we don't need a CT as initial diagnosis. Often these patients will need CTs during their hospital stays. And of course, with contrast, there's risk of nephropathy and the radiation in early complications. So it really doesn't change our management. It's going to be more helpful a few days later to risk stratify and prognosticate. And, you know, again, speaking to the emerge doctors and my wife, who's probably listening on, is if you're worried about other diagnoses, of course, you know, we're not going to say never do a CT, but, you know, in general, if it's straightforward pancreatitis and you're confident with that diagnosis, there's no need for imaging at that time. So initial management, this is really where we can all make the biggest difference in terms of helping these patients along. So the most effective treatment, and really the only treatment that's been shown to affect morbidity, mortality early on, is IV fluids. We have massive third space losses related to the inflammatory response. You get increased vascular permeability. These patients often get very, very hypoalbuminemic quickly. They get massively distended, and of course they get more so with IV fluids. But really what we're trying to prevent is this idea of hemoconcentration and ischemia at the level of the pancreas that then leads to the pancreatic necrosis. So all of the fluids we're giving, in addition to preventing, of course, renal dysfunction and subsequent renal failure, we're really trying to actually help perfuse the pancreas through this acute insult, and giving fluids we know reduces the risk for necrosis. So I'm not going to go into too much detail, but I understand that when the pancreas is inflamed, you get significant inflammatory response. It causes often widespread cellular dysfunction. You get a surge response, and these then lead to capillary permeability. You get big third space losses, and eventually you can get hypovolemic shock and multi-organ failure. And that's the pathology and the pathogenesis of why acute pancreatitis gets so dangerous. And if you look here, we have a normal pancreas, we have an edematous pancreas when they're presenting to you. And the goal is really to maintain perfusion and do everything we can to help support the pancreas so it stays edematous and doesn't progress to necrosis, which is the dreaded complication, which, as you saw, has an exponentially higher mortality rate and a lot more complications. So it's really a balancing act for fluid. When I was in medical school, we used to give amounts of fluid that we usually think about for burn victims. Like we used to give 3, 4, 5 liters up front, running 250 cc an hour. And just like how evidence has evolved in the setting of upper GI bleeding and transfusions, the evidence is evolving for fluids and pancreatitis. So it seems that, you know, like a lot of things, moderate is best. So too little is not good, but neither is too much. And so for your average 70 kilogram patient, I don't know if that's always so average anymore, but we usually give about 10 cc's per kilogram initially, and 100 cc bolus. So it doesn't seem like that much, but I'll get back to that after. Ringer's lactate's always preferred over saline. There's good evidence that it seems to be better. Patients tend to do better. Only caveat, if it's a rare case of hypercalcemia-induced pancreatitis, you don't want to give Ringer's lactate. You want to prefer saline. The thing I'm going to harp on is that it's not simply a matter of set it and forget it, give a 10 cc bolus and see them in a couple of days when they need their CT. It's really about goal-directed therapy. And the first 24 hours is most important, and the first 40 hours is almost as important. You want to titrate based on clinical parameters. So based on the BUN, based on the hematocrit, and based on urine output. So that initial bolus and their maintenance rate is just a starting point, which was used in some of these recent clinical trials. But you need to target a decrease in the BUN and a decrease in the hematocrit. And so that's really the important thing, is not to just set it and forget it, but to monitor these patients closely. So again, the only thing that's been beneficial in these patients is fluid. So as the emergency room physicians, I definitely urge give these patients fluid, which is typically being done. And, these patients shouldn't be sitting, without IVs in the emerge for many, many hours. We're doing them a disservice. And again, on the wards, we really want to make sure we're adequately resuscitating them and keeping a close eye on the first 24 to 48 hours. And we rely, of course, on, our hospitalists, our internists, our nurses to keep a close eye on this. And so I'm going to propose, people might take offense to this, especially Chris, but, even several years ago, it was like the time to antibiotics improves outcomes, and the time that we delay antibiotics, patients do worse. So it's kind of the same thing in pancreatitis, not as dramatic, but we're always trying to make GI seem as serious as ICU and other stuff. But in these cases, if you don't do a good job, they will end up in the ICU. But, IV fluids early is important, and that's really the mainstay of treatment. It's the only thing that we can do early on. Everything else is, is for comfort and for supportive measures and all the fancy things we can do later on when things go wrong. But up front, that's really, the number one thing that we have to do. So we always learned about scoring systems in pancreatitis, ransom criteria, patches, all kinds of scoring systems that will take you 30 minutes to do. And they basically shown that they're not helpful. So they don't really prognosticate particularly well. It doesn't change the management because the management is fluids regardless. And the SIR score, which is very simple, which just takes into account very readily available information, CBC and information from the vital signs, performs just as well as classifying these patients. And really the goal to classify is just to know if you need to call Julio or Chris or Anna in the middle of the night and say, like, this patient needs to go to the ICU because they're acute pancreatitis, they look really unwell, or if this patient's suitable for the ward. And when patients are clinically unwell on presentation, it's a bad prognostic sign. Of course, we didn't get into some of the other details, but patient factors like do they have underlying heart failure or kidney disease or liver failure or obesity or insulin dependent diabetes and other things that of course make them higher risk. But really it's a clinical assessment that's going to judge their level of monitoring. So another question that comes off, there's no role for antibiotics at initial presentation. Often people get scared because the patients look unwell, they're tachycardic, they're hypotensive, their white blood cell counts elevated, and they're often thrown antibiotics. It doesn't make a difference. You may be harming the patients, exposing them to various antibiotics, especially if they need more antibiotics later on. Of course, if there's an alternative diagnosis suspected, if they have concomitant cholangitis or cholecystitis or something else, then you would treat as usual. But for run-of-the-mill pancreatitis, even if the patient's really unwell, even if they're requiring ICU level care, we don't typically use antibiotics. So back to our case. So it's day 4 in hospital. He's having a lot of pain. He's nauseous. He's not eating or drinking very well. But clinically, he looks distended. His abdomen's sore. He's stable. He's afebrile, but he's quite edematous. And he's not moving very much, and he's just kind of lying in bed all day and uncomfortable. At that point, we're getting a CT with contrast. A few days later, we want to get an idea of which way this is going, and unfortunately show the evidence of necrosis that's developed and some fluid around the pancreas. So another evolving change in acute pancreatitis is really for these mild pancreatitis, which isn't our patient that we're talking about. The patients that come in and again are clinically well, they come in with pain, but they're not hemodynamically unstable. They're not requiring ICU level care. Typically, these patients will direct their own sort of oral intake. If you're seeing them and they're very uncomfortable, they're nauseous, they're vomiting, certainly we're not going to put food down, but if they are hungry, if they want to eat, if they want to drink, we should definitely allow them to do so. It used to be that we thought keeping these patients NPO would rest the pancreas and we should keep them NPO for many, many days, and all of that sort of being tossed out the wayside, and there's good evidence to suggest that in these low risk sort of mild pancreatitis, they can actually go right to low fat diet, and it actually decreases their length of stay. It lets them get out earlier. They don't have any worse outcomes. And there's no need to do that slow progression, clear fluids, full fluids, low fat diet. In severe pancreatitis, for those of us that have managed these patients often, they're not keen to eat. Typically we're not too worried about a lack of oral intake over the first 4 to 5 days, but at that sort of 5-day mark, it's usually when the dietitian is starting to call me and saying, hey, Dr. Fortinsky, did you forget that this patient hasn't eaten in 5 days? And I have to pretend like I didn't. But in all honesty, that's the time that you need to start thinking about how you can start feeding this patient. People will always ask about TPN, and the answer is absolutely not, under no circumstance, unless we have no other option. So the first option when these patients don't want to eat or drink, or they can't tolerate much orally, is to put an NG tube in. Again, there was discussions about NJ and post-pyloric feeding to bypass the pancreas. That's all being, again, tossed out as sounds good in theory, but is not proven in clinical trials. So NG is simple, can be done at the bedside, and can start trickle feeding, and with the help of our dietitians to try to get them some nutrition. Sometimes there'll be gastric outlet obstruction, there'll be gastroparesis around hydroscope fluids. Sometimes there probably is some benefit to NJ feeds, and that can be considered. You always want to exhaust any potential option for enteral feeding, and very strong recommendations to put in NJ feeds, even with elemental diets, that can be trickled in, and that's far better than TPN. TPN in these patients in randomized controlled trials, not simply observational trials of the sickest patients. TPN-related trials show worse morbidity, worse mortality, worse infectious complications. You're doing a huge disservice putting them on TPN. And so we almost never, ever use this. And even in the context of severe ileus constipation, those patients are still better off with trickle feeds, giving enteral nutrition. It reduces infectious complications, it reduces all-cause mortality. And so, again, TPN is a big no-no. And if you're going to use TPN, it's going to have to be very cautiously and with a very clear goal of trying to temporize or needing some nutrition before undergoing a massive abdominal surgery. And find a dietitian to help in these cases. They're often extremely helpful in terms of trying to estimate floor intake, and you don't necessarily need to get them to their ideal floor intake right away, but the more the better, and just try to persist with enteral nutrition as much as possible. So key takeaway number 3, TPN is the last choice. And again, to bring this point home, and I have all my references at the end, I just didn't want to bombard you in the slides, but there's been a meta-analysis of 8 randomized controlled trials looking at enteral versus TPN, and it reduced mortality, multi-organ failure, infections, and need for surgery. So certainly TPN should not be used. So other considerations in management, and again, some of these I'm sure go without saying, but pain is a huge issue in these patients. They're often suboptimally controlled, and it can be very challenging to manage their pain. Typically what we'll try to do is offer them PRNs on an hourly basis, try to see what they've taken in 24-hour period, and then try to convert some to long acting. Obviously, getting the pain services involved for PCA pumps and things like that can be considered. Pain is very, very severe, and these patients can go on for many days, many weeks, and really be the source of problems for these patients, even when they get out of the hospital. Nausea, GERD type symptoms are common. They get a lot of inflammation in the stomach, and the duodenum and PPIs tend to help. They often develop ileus, all fluids, and the pain medications in addition to constipation. So trying to manage their electrolytes, trying to get them up and moving, trying to get them laxatives can all be very helpful. After the first 48 hours, we often watch these patients stay very fluid overloaded for weeks and weeks and weeks. And so, the big point is that we want huge volume and fluid resuscitation intravascularly initially to prevent the pancreas. And I know we said moderate, but we're giving a lot intravascularly to try to help these patients. A lot of this fluid is going extravascularly, and it's going to lead to a lot of complications because they're not going to be able to eat. I've seen patients with very swollen legs get DVTs, and the point is, after the first 48 hours, there's absolutely no benefit to fluid anymore. So at that point, obviously, if they have a bit of renal dysfunction, if there's other reasons to give them fluid, sure, but you're not giving fluid for the purpose of the pancreas. That should be safe. So try to bring their total volume of fluid down to improve their overall sort of functioning. And DVT prophylaxis should be given to all these patients. They're at very high risk for vena thromboembolic complication, portal vein thrombus, splenic vein thrombus, DVTs, PEs, etc. And it can make management very difficult. So the next area is after we've managed these patients, after we've sort of done initial workup and fluid resuscitation, we really want to figure out, well, why did they get pancreatitis? So I put on some chips because if you're going to gamble and you're going to bet on what the cause is, 2/3 of the time you'd be right just saying gallstones. You don't need anything else. The ultrasound in emerge was normal. The liver enzymes and bilirubin were normal. The patient didn't have pain before. The patient had no history of gallstones. It's 2/3 of the time it's still gallstones. If I get called all the time, it's not stones or, most likely it's still stones. We'll get into that later. Alcohol, obviously taking a good history, that's all we can do. Sometimes I have, people that, again, are misleading about their alcohol use, but on the flip side, some people are adamant that it's not alcohol and they don't drink. And we've never seen stones. So people are so focused that they must be lying about the alcohol, but it's still stones. So, and then other causes, which we talk about all the time, and, is this autoimmune pancreatitis? And I would say more patients probably get IgG4 levels on presentation with acute pancreatitis than adequate fluid resuscitation. So these are very rare. All of these other causes make up 10%. Of course, if they've had a recent EUS and biopsy, we think about that. If they've had a recent ERCP in the last 24 hours, and there's rare other causes, medications, cancer can occasionally be around with pancreatitis, hypertriglyceridemia. We see a few cases a year, and autoimmune is rare. But again, these are really, really rare ones, and low on the differential. So how do we figure out about gallstones? So abdominal ultrasound is a great first test. You see stones in the gallbladder, you see sludge, you see a dilated bile duct, that gives you some degree of suspicion. There's some evidence that if the initial ultrasound is normal, you can consider doing one a week later. It just seems like the more times you do the test, occasionally you're going to pick something up that's not perfect. And if the patient's coming in with slight rise in liver enzymes or bilirubin, that just raises the stakes and makes you even more suspicious. So gallstones and gallbladder are typically easy to detect. CVD stones, not so much. Again, we'll see patients get an ultrasound initially, and then the next test orders a CT to look for CVD stones, and that's the wrong approach. The CT is less sensitive than ultrasound for CVD stones. So really, if you're worried about that, we'll typically go to MRI. EUS is a little bit better than MRI, but obviously MRI is easier to get. It's non-invasive, and if it gives you information, it's simple, but often we'll end up going to EUS if there's any concerns. CVD stones, honestly, the best way to describe them, they're like ninjas. They can cause havoc. You can't see them at night, and you can often miss them. Patients with prior gallbladders out still get CVD stones. We see this all the time. So having your cholecystectomy doesn't guarantee you never have an issue with stones. We'll see often this, mildly dilated bile duct. If it's 6 millimeters, it's probably normal. If it's a bit larger than that, and somebody with their gallbladder in, then worry. If it's more than 10 millimeters and someone with their gallbladder out, that's dilated. Patients on chronic opioids, those numbers can be vastly different, and so it can sometimes fake you out. But those are the things on ultrasound or CAT scan that you're worried about, is if they've absolutely validated, you're sort of suspicious. Sometimes liver enzymes can come back down and bilirubin can normalize. Doesn't always mean the stone's passed. It might just not be blocking. It might just be sitting in the duct. Often we learn in medical school that ALP is, that's what happens in bile obstruction. I don't know why they taught us that, but it's not rough. It's not right. Patients don't follow a textbook, and often it's the ALT and AST that evolve first. ALT tends to be more for chronic biliary obstruction. Acutely, it might just be the ALT and AST, so don't be too focused on that sort of cholestatic pattern, and it doesn't look cholestatic because it doesn't really hold up in reality. And again, normal bilirubin doesn't exclude stones, so you really have to look for stones really carefully in these patients. So just to put us all on the same page, what happens when stones are at different places in the bile duct, or the gallbladder? So if it's lodged in the neck, this is a surgical issue. So this is acute cholecystitis. It's blocking the gallbladder. These patients often, again, present with pain, fevers. They shouldn't be jaundiced. They shouldn't have elevated liver enzymes. It's clear. If a stone travels down and it escapes the neck and gets lodged in the bile duct, these are our really sick patients. Often, need urgent ERCP. This patient should have elevated liver enzymes, bilirubin. They need antibiotics. Sometimes patients are asymptomatic and stones are picked up for other reasons, or they have intermittent pain, but the stones aren't blocking. So this is what we often can find in patients who present with gallstone pancreatitis, that there can just be little stones or sludge sitting in the duct. And in pancreatitis, we're really seeing a stone or sludge even that's sort of traveling through the bile duct and getting stuck right at the exit point of the pancreas and bile duct, at the ampulla. And often these stones are very small. They can often just be sludge or thickened bile that blocks the pancreas duct for maybe seconds or minutes, causes rip-roaring pancreatitis, but they don't have biliary obstruction. And the stone and sludge is long gone, and any test you do, it's already gone. And that happens sometimes. But these are the patients that are presenting with gallstone pancreatitis. The majority of them are very small stones that have made it down the bile duct and block the pancreas duct. So how do we manage gallstone pancreatitis? So again, a lot of the stones and sludge have already passed, so you don't necessarily need an ERCP. If the patient has cholangitis and they're unwell, that's an indication for urgent ERCP, even in the context of pancreatitis. The cholangitis takes precedence. If it's just gallstone pancreatitis and there is a suspicion for stones or sludge or something seen on an MR or an EUS, we do suggest ERCP to clean the duct, but it's typically held off for the first 72 hours, give fluids, give the pancreas as much time to resolve, and then do it. There isn't an urgent need to sort of take this stone out and acutely unblock the pancreas. Doesn't work like that. We typically recommend cholecystectomy during the same admission for gallstone pancreatitis. The caveat would be is that if they've had severe necrotizing pancreatitis, they're edematous, but the surgeon will say it's too high risk and they'll delay. But I'll typically say for mild to moderate pancreatitis, the surgeon should really take the patient to the OR during that same admission. It reduces recurrent pancreatitis in the interim. And if they're not a surgical candidate, or if they've already had their gallbladder out, it'd be nice to ask the surgeons to take it out again. But we can consider obviously doing an ERCP and trying to basically make a cut in the bile duct so that stones and sludge and other things will pass through without blocking the pancreas duct. So that's sort of an alternative measure. And so if there's no alcohol, there's no stones that you can see. We're thinking about these zebra cases, and zebra cases are those cases that are rare that we always think about, but they rarely are what the cause is. And so triglycerides have to be really high to cause pancreatitis, usually more than 11. Cancer or mucinous cysts, again, these might typically be older patients. Sometimes a patient may tell you they've been losing weight, they've had chronic symptoms. But again, patients with pancreatitis who are older typically should get some imaging of some kind, whether it be a CT or an MRI afterwards to rule that out. Certain medications, and I'll touch upon a few of those after, Hypercalcemia is a rare cause. Autoimmune or IgG4 disease, again, very rare cause, but as sort of a local pancreatologist, I do have a fair number of these patients, but in the grand scheme of things, these happen very rarely. Anatomical variants like pancreatic divisum is a bit controversial. And again, in these patients where we don't have a clear cause, EUS is usually the next best test just to look for other things, and often looking for small stones or sludge, but sometimes I can see other abnormalities as well. So I don't want to bore you guys too much, but there's various medications that can cause pancreatitis through various mechanisms. I won't go through all of these, but there's been so many medications reported as causing pancreatitis, and some are early on, meaning within a couple of weeks of starting, so it's more obvious diagnostically. Oh, I just started on this medication, and 2 weeks later they show up with pancreatitis. It makes you wonder, but some of these can be medications that they've been on for many months or years even. And then it becomes less obvious, and we often feel like don't blame that medication. We've been on it for years, still again, look for stones and look for other things. So here's a list just to give you an idea. If you were to do an up-to-date search and say, oh, is this medication being associated with pancreatitis? The answer is probably yes. But class 1A is really the ones that are worrisome. Those are studies that have been done that have shown withdrawing the offending medication and then reintroducing it, causing pancreatitis. Class 1B have been patients that they've studied, again, that have been associated with pancreatitis in multiple case series. And then these other two are really rare, sometimes even reported like once or twice in literature. And to be honest, I probably would just ignore most of those because they're such common medications. And again, it's probably stones that caused it, but they're blaming a potential medication. So it's now 10 days into this poor guy's hospital stay, and he started to tolerate some boost drinks. He's getting towards that sort of desired caloric goal that's being set by our dietitians, and he's looking okay. He's afebrile, he's stable, sitting on the ward. He's still volume overloaded and deconditioned, but he seems like he's sort of getting over the hump. He had an MRI, it was negative for stones and sludge. He had a full workup, it was all negative. So is this idiopathic pancreatitis? What's going on here? And so again, based on the evidence, and there's been lots of studies, and again, all the references will be at the end of the talk if anyone's interested, but looking at over 2,000 patients with quote unquote idiopathic acute pancreatitis. So meaning we have a full workup. They've had MRs, many of them have had endoscopic ultrasound. They've had full workup for secondary causes, look at medications. And there's a significant reduction in recurrent pancreatitis if these patients go on for cholecystectomy. Another randomized controlled trial looked at this topic and found the number needed to treat of 5. So not very many when you look at some of the drugs we use, with numbers needed to treat of far higher. So 1 in 5 patients will have a reduction in their recurrent pancreatitis. There was a meta-analysis that looked at a bunch of randomized controlled trials, reduced recurrent pancreatitis 40% and 10% with a cholecystectomy. And the latest guidelines have just been comprised of the most expert opinions across the US, said that once you've had a second episode of acute pancreatitis without a clear cause, assume it's stones, take out the gallbladder. So this is takeaway number 4, is if you've had a second episode of acute pancreatitis and you've had your workup, gallbladder needs to come out. Will often get pushed back at times, and there'll be discussions, and that's why I really wanted to highlight this evidence that's saying, well, we've never seen stones. You don't need to see stones. The stones are often there. I just had a case of a young guy that had his 5th episode of acute pancreatitis, and he saw me as a second opinion, and he had actually come into hospital with his 5th episode, and he'd been admitted to various other hospitals the first time here at RVH. And after reviewing his, and after about 5 minutes, I said to him, you need your gallbladder, and he was dumbfounded. He's like, I can't believe that. Like, that makes no sense. I've had every test. I've gone through everything. Nobody's ever said that they can find the cause. And I said, well, you're at the fifth episode, and I actually brought up these guidelines and I said, all the evidence is suggesting that this is stones and fluid, otherwise it's not a drink, he's otherwise healthy. And we took out his gallbladder. And actually his gallbladder pathology showed chronic cholecystitis. And so again, sort of tips that scale for something being wrong with his gallbladder, and obviously reassured him afterwards. But again, every test under the sun was done, it was all normal. And even had there not been an abnormal gallbladder, we know from the studies his risk for pancreatitis would go down. So about a week later, and all of a sudden, CCOT's called, and the patient's really unstable. He's febrile, he's tachycardic, he's hypotensive, he's on the ward, and he gets rushed down to CT, and he's got a big new complex fluid collection. There are molecules of gas, and obviously the presentation is very concerning for infection. He's transferred to ICU, started on broad spectrum antibiotics, neuropenem, and the dietitian is frustrated. And this is when I typically get called, Kyle, he hasn't been eating, and I pretend like I remember that. And then they say, well, he's going to need TPN because he can't caloric intake. And I'm going to say the same thing I said before, that it's just a bad idea. And it's, again, in cases like this, it's really about sort of acute care management in terms of now he's septic, so he needs his fluids, he needs his antibiotics, and we'll talk about how to manage some of these complications. This is kind of the exciting part of the talk. So the early complications of acute pancreatitis that we see in hospital, sort of fluid collections and necrotic collections, thrombosis, ascites and pleural effusions, biliary obstruction, and gastric outlet obstruction. For the purpose of this talk, we'll talk mostly about the fluid collections, because if not, this talk would probably go on until next week. So when we classify the fluid collection, it's really important, again, to separate interstitial pancreatitis from necrotizing pancreatitis, and the time is important too. So in the first 4 weeks, these are classified as an acute peripancreatic collection or an acute necrotic collection. After 4 weeks, it's a pseudocyst, which I'm sure we've all heard the term, and walled-off necrosis. And the reason this is important is in the first 4 weeks, we typically can't drain these collections. They haven't fully formed. They're basically just fluid collections within the abdomen. And if you try to poke a needle or try to drain these either through radiology or through the stomach, you can actually just contaminate the entire abdomen, and bad things happen. So in early fluid collections, especially with interstitial edematous pancreatitis, the fluid often resolves, and sometimes within a couple of weeks. Sometimes these patients will develop pseudocysts, but only a very small percentage will develop pseudocysts that will persist beyond a few weeks, and often these patients will show up several weeks later, if not months later, with large collections that clearly at that point aren't going to resolve on their own and need drainage. So here's a CT scan, and so this is actually the pseudocyst here, this big collection, and this is the stomach. So typically the stomach would be occupying most of this, but you can see this big pseudocyst, which you're going to have to believe me is probably about 8-9 centimeters, is compressing the stomach. And patients like these will, typically be symptomatic. And so the reasons to drain these cysts after these acute episodes have resolved and you're at least 4 weeks out is they're having a lot of pain, they're having nausea, they're having difficulty eating and drinking, they're losing weight. Sometimes after the 4-week span, they can still develop infections. And so that's an indication for drainage. They can often present with gastric outlet obstruction because it's compressing the stomach or the duodenum. And occasionally it can also compress the bile duct, and they can present with jaundice. So patience is really the key here. There's a very high morbidity and mortality if you try to drain these early, as I mentioned. We need to treat with IV antibiotics that penetrate the pancreas well, and typically it's carbapenems. And you need to delay at least 4 weeks. So this really sick patient who's in the ICU, as much as it's tempting, like a lot of abscesses in the abdomen, they say source control, we need to drain the abscess or we won't control the infection. The same doesn't really hold up in acute pancreatitis. Typically, they settle with IV antibiotic. Of course, if they're still unstable and don't settle, they may need to go for urgent surgery. But other drainage is really, really risky in the first 4 weeks. For gastric outlet obstruction symptoms, we would consider again either NG or NJ tubes to try to bypass that. For biliary obstruction in these early collections, we'll do ERCP with stenting. So you try to work around trying to drain. In terms of options, once we've got into that 4-week mark, then we have a few different options. So percutaneous drainage is an option. It tends to be reserved for collections that aren't sitting right beside the stomach or small bowel, sometimes pelvic collections, sometimes retroperitoneal collections, and often it's used in combination. So if there's a big collection that's sometimes partially near the stomach, partially in the retroperitoneum or diving into the pelvis, you'll often see patients with stents put in by myself or another therapeutic endoscopist through the stomach, and then other percutaneous drains through the back or the abdomen to get into the retroperitoneal space. Sometimes surgeons will use percutaneous drains and actually do various video-assisted debridement through those drains. The problem with percutaneous drains for that CT I showed you with the big fluid collection abutting the stomach is twofold. Number one, they don't have a way to debride debris. So if some of these collections are filled with debris or necrotic tissue, the small drains cannot successfully debride that. Sometimes that stuff will liquefy, but often it won't. And so you're stuck sort of in limbo, not being able to debride them. The other risk is that some of these collections will form because the pancreas cleft is no longer in continuity because of the episode of pancreatitis. And so pancreatic fluid will constantly fill up these collections. So if you try to stick a drain in it and pull out the drain after a few weeks, the fluid will just reaccumulate. And sometimes you'll create a fistula from the fluid collection out the abdomen, which, as you can imagine, isn't too pleasant and can cause a lot of problems for the patient. So we prefer an endoscopic approach, if possible, to solve those issues. So we can drain directly through the stomach or the small bowel. We can debride through the stent, as I'll show you in a video coming up. And we can also eventually leave stents between the stomach and this fluid collection, so that fluid can continue to drain forever. And often these stents, these plastic pigtail stents, will stay in forever just to keep that shunt open, because the pancreas always drains to the stomach and bowel eventually. So this is just another way for it to drain, and it's totally safe, and patients can live forever with these little plastic stents. Surgery is very helpful in certain cases, but it has the highest risk. So again, in an early unstable pancreatitis who's in the ICU not responding, when we've had a couple of these patients, they'll get transferred down to Toronto for urgent laparotomy and debridement, and these patients are very sick and the outcomes are poor, but they don't really have anything to lose at that point. But typically surgery is reserved as a step-up approach in patients that have failed endoscopic, failed IR drainage, and we're looking to sort of determine drainage. So here's the stent that we use endoscopically. So we can basically use cautery to drill through the stomach or the small bowel. We deploy a stent, and this is actually not a cyst this was draining. This was actually a gastrojejunectomy that we made connecting the stomach and small bowel, but it's a nice CT to show you what it looks like. So it opens on one side, opens on another. It's like a dumbbell appearance, and then the center that allows for things to travel through. And in the case of cysts, we'll let them drain. And so I have a video courtesy of our friends at St. Mike's, just because I don't have the ability to film videos here yet at RVH. So I just wanted to show a video just for a couple minutes, and I'm cognizant of the time, so try to go quick. Please. The lights up front. Yeah, perfect. So that's basically a stent going into a fluid collection under ultrasound guidance. And on the bottom left there, you can see the endoscopic view of this stent, the proximal flange being deployed. And as soon as it deploys, you've now created a connection between the stomach and this large fluid collection. You can see it's draining lots of stuff. And then the beauty of this technique is that you've now created a window by which, if there's necrotic tissue inside of the collection, we can actually take a regular gastroscope and just go through this stent into the pancreas and what's left of the pancreas, and actually start breaking up tissue. So that's what the stent looks like as it's deployed into this collection. And then when you go in with a regular scope, you can start to see dead tissue and pus coming out. And we'll literally take a snare and grab this dead tissue and pull it out. And again, this is a non-invasive way. This is inside this collection, inside the abdomen. And we can clean out, we can flush this. And often I'll bring these patients back every week for a few weeks. And some of my nurses will know that the smell of this isn't great. But the patients feel a lot better afterwards. And it's an amazing technique that we can do to spare the patient surgery. And then eventually, once these collections are totally debrided, we'll pull out this metal stent. And this is the end of the collection. That's all cleaned up at the end with very little residual tissue. And then we'll place some plastic stents afterwards to keep this open, and it will forever drain into the stomach. So that's kind of one of the cool procedures that we can do here. And here's a picture of one of the ones we've done here at RVH. Similar technique you've seen. So delayed intervention, this is one of the last takeaways, and then we'll get some questions. So endoscopic drainage is preferred. Feel free to call me for these cases, and we'll try to help and get these done. And really, I'll end with this slide. Teamwork is really the approach in pancreatitis. And I know it's cliche, but really I can't think of a better disease to talk about. Everyone who's involved, from the ER with the diagnosis, from our hospitalists and our internists giving fluids, figuring out the cause, from our ICU and ID team, for GI, general surgery, IR, doing various endoscopic and surgical procedures, to our dietitians, of course, to our PTs and OTs who are constantly bugging to try and get these patients up and moving, and obviously to our RNs, RPNs, and I should have said physician assistants as well, who are helping along the way and trying to get these patients out of hospital. And often I've seen cases where, and I won't say who in the ICU, but I totally understand why. Young patient, necrotizing pancreatitis, and there was discussions at one point to say, should we make this patient palliative? And I remember going into discussions saying, this is a treatable disease. These are the sickest patients often in the entire hospital. It can go on for months. It can be a treacherous, a very difficult process. They can, get better, get worse, get better, get worse. But, this patient in particular, who is, I wouldn't say almost made palliative, but the thought across people is, how much is this guy going to take? Literally, this one particular patient I'm thinking about came in my office, gave me a hug. He's like taller than me, he looks fitter than me, and he's doing absolutely amazing. And he was like on death's door with acute pancreatitis. These are often healthy patients, you hope, that have a terrible disease that's mostly reversible, but the course of hospital can be long, it can be rocky. But the amazing thing, and sometimes we don't see this in the ICU, and sometimes I think we should have a little round sometime in the ICU, bring back all these patients to come, walk through the ICU again. But it is amazing, right? Thanks to everyone's care. It's amazing for me sometimes to see the transition from on death's door to really just looking like anyone else, walking and doing their job back to work and moving on with their lives. So it really is amazing This guy got off all his opioids. Most of them do eventually. They often will return to work and do normal lives. I usually tell people it's about a year to get back to normal. It really, for these severe patients. But I have several of these I follow through my practice, and it's really rewarding. And they're always so appreciative of all the care they receive. So, I left a couple of slides for US, but we're running late. It's a great procedure. We can use ultrasound to take biopsies of things. Many of you refer lots of patients over, and I appreciate it. We can take biopsies of pancreas. We can do it at the same time as ERCP. And more recently, in the last couple of years, we started doing drainages. We started debriding pancreases. We can coil and glue varices through the stomach. We can directly drain the bile duct through the small bowel. We can drain the gallbladder. We can inject for pain. And we can create gastric jejunostomies through the stents non-surgically. So lots of references. Sorry that I went a little bit over time. It was well intended, just to try to give everyone a good piece of information. I hope it wasn't too much, but thanks to everyone who showed up online and showed up in person, and thanks to Chris for asking me to talk, and thanks for everyone for helping managing these complex patients. And again, if there's ever patients that you're worried about, I'm always available to talk. You can get them through located, and you can email me. I'm happy to help any of these patients. Thanks for coming. And
I want to thank Carlos.
Thank Kyle for this awesome talk. That was, the takeaways were all pearls. It was great. Anyone have any questions for Kyle before we go online? Dr. Snetti?
With those stents, what's the chances of complications of them becoming obstructed? So
typical emerge doctor question. Like how is this going to increase volumes in the emerge? So the acute complications really from these stents which happen are the big ones, bleeding. So the more we do, the more we're going to see. Typically, again, those patients will present like an upper GI bleed, but when you look in their chart, if you do so, it can happen at any time, and it can often lead to pseudoaneurysm, and these patients can bleed like stink. So if they've had any of these sort of stents put in, typically it'll be like straight to CT for a possible angio, and we've had one case in particular that needed IR embolization of a couple large vessels feeding into that stent. Other complications, obviously the stent can migrate, the stent can move, but typically they're well tolerated. And again, if they get blocked with necrotic material, they can present again with infection, and in those cases we'll often just go through the stent, clean it out, and debride. But I would say the big thing to worry about is bleeding. But anyone who's had any of these procedures coming in with a lot of pain knows for sure they're going to get a CT to get blood work. So that's sort of the session. And again, if it's my patient, of course, I'm always happy to field calls. And if I know if the patient's coming in, then I'll try to give people a heads up. But the main things to watch out for are bleeding. And if I'm not available, call in because she knows what to do.
Any other questions? That's it. And Christina, number.
Thank you. Evidence of the development of diabetes.
It's a great question. I will say it totally depends. Some of my patients will focus on the percent of necrosis, and they'll often say to me, how much pancreas do I have left? And I just say it doesn't matter. Because, and it's similar to looking at a liver that looks cirrhotic on imaging, and they ask, how cirrhotic is the liver? It's like, well, how is it functioning? So we don't know why some people develop pancreatitis, why some people don't, or so why people develop diabetes, some people don't. The vast majority who have severe necrotizing pancreatitis will almost certainly have diabetes, and most of them require insulin while they're in hospital. A huge percentage of them, if their pancreases will recover sufficiently, and they're often off insulin by that sort of 6-9 month mark. But there's no guarantee. So I always tell the patients the same thing. I say it's a known complication. Same with exocrine insufficiency in terms of pancreatic enzyme replacement, which we often give. It's We don't know how the pancreas is going to recover. We don't know how the islet cells are going to produce insulin. It's really just a matter of time. I would typically think that at about the 6-9 month mark, if they haven't recovered and they're insulin dependent, they're not going to recover. So I can't give you an exact percentage. All I can say is if it's acute interstitial, like edematous pancreatitis, the risk is very low. If it's necrotizing pancreatitis, the more pancreas affected, theoretically, the more likely they're going to have diabetes, but not always. But they all need to be monitored for their blood sugars for diabetes, both in hospital, after hospital, and followed. But in my experience, a lot of them end up getting off insulin long term. The weight loss in hospital probably helps it.
Any other questions? So any?
With the mild pancreatitis, that's often a patient population that clinically well enough to discharge home. Is there any, and the reason I say that is because yes, I'm an emerge doc, and yes, low matters and beds matter, and oftentimes they are well enough and smart enough to go home and come back should things change. Is there like a good clinical tool?
It's a great question. What I would say is acute pancreatitis, if that's the diagnosis, they get into hospital. There's no discharge in these patients, right? Because again, like we said, the course isn't always linear. Patients who present with mild, if they don't get fluids, they'll come back with severe. So,
Oh no, this is like after regular merge, so they get all their fluid, they get their bolus.
yeah, it's still
No end organ dysfunction, they literally are.
not for acute.
Morbidities.
With the wall.
They all need to be. What?
So I just listened to Dr. Fortinsky.
But wait a minute. I want to clarify. I'm gonna hear my pre-op, okay? I don't know how to say this politically, but I'm an emergency doctor, so I'll just say it how I'm saying it. Okay, I'll just say it. Just because an emergency doctor calls it illness and says this has acute pancreatitis and needs to be admitted, it doesn't mean it's actually acute pancreatitis.
There we go, there's better way.
So there we go. So I'm trying to think of a better way to say it, but there is. So if this pain has been going on for several days, right? If the pain has been going on for several days, and the lipase is like 150. Again, in those weird cases where the pain's been going on for a while, you probably are going to get a CT scan, right? So in those cases where the lipase is not really very elevated, it's not classic, the pain's been going on for days, those are the ones I think you're thinking about in terms of like, this is mild duodenitis, this is, been going on for several days. It might come up in terms of the diagnostic code and in terms of, oh, this is pancreatitis, but that's not really acute pancreatitis. If acute pancreatitis is severe, sudden onset pain, usually they're coming into emerge because if they have pancreatitis, they're not sitting at home for several days. So in those patients, they all need to be admitted. But in those mild lipase elevations, like 150, 200 with a bit of discomfort, again, if you CT them and there's no pancreatitis, then you could probably argue it's not acute pancreatitis. But if you're making the diagnosis of acute pancreatitis, they all need to get admitted because there's nowhere on any of the literature that says that based on your clinical presentation that you're outside of the woods. The only time they're out of the woods is at that 48, 72 hour mark if their pain is fully resolved, plus or minus a CT scan. So that initial, if it's pure pancreatitis, everyone is fluid. I'm glad you clarify that. So they all need IV fluids, they all need close monitoring for 24 to 48 hours. So I guess the one possibility is you could keep patients in emerge for 48 hours.
No,
That's it. So it's there. You heard it there. Perfect.
I will call you first.
But I think we can try to make it smart. Any other questions for Pat? Any questions on okay. Listen, thanks so much. Physicians who are in the room, if you scan and do your evaluation of reference with the QR code, we'll send you CAB. Everyone else, please scan the QR code, give feedback on rounds. Again, one last round of applause for your presentation.
That's good.